just like to thank Marco and the Sobrice organization for this invitation. It's my pleasure to talk to all of you about irreversible electroporation. The idea is to give you an overview of what this technology is and the applications and a little bit about the data, and then we should have some time for questions. So see if I can move this forward. Okay, so what is electroporation? So we're all familiar with thermal ablation with radiofrequency and microwave, where you use heat, or cryoablation, where you freeze the tumor. Electroporation is the newest technology in the ablation space. It's been around for the last 10 years now. The technology uses high voltage, low energy DC current, and when you expose the cell to the electrical energy, it changes the transmembrane potential and causes disruption of the cell membrane, and thereby it disrupts the homeostasis mechanism and leads to death of the cell organelles, whereas the cell membrane is riddled with holes and then is removed by the body by apoptosis. The technology has been around for several years, a few decades actually, where they use the energy at a lower level, up to 1,000 volts, for what is called as reversible electroporation. And this technology has been used to insert proteins into cell membranes, molecules, cell fusion, and also electrochemotherapy for skin cancers. So when the researchers at University of Berkeley were working with the technology, and they increased the voltage from 1,000 to 3,000 volts, they realized that there was cell death independent of the chemotherapy, and that's how irreversible electroporation was born, and it was commercially introduced as the nanoknife back in 2009, early 2010 by AngioDynamics. So it's considered a predominantly non-thermal ablation therapy that uses high voltage, low energy DC current to create the permanent pores in the cell membrane. So this is the generator of the machine. In the middle, what you're seeing is the electrode. You need 2 of these to create a circuit or a treatment zone, a positive and a negative. And on the far right, what you're seeing is called the AccuSync device. I will talk about that in a second. You need a positive and a negative. So here in the generator, you see you have 6 slots where you can connect electrodes. So you can use a maximum of 6 of these, depending on the size of the tumor that you're treating. And the AccuSync device is a independent device that is now part of the nanoknife system. This is a 5-lead system with a printer. It is gated to the patient's EKG, and it's now part of every nanoknife machine. And the role of the AccuSync device is to make sure to reduce or eliminate the risk of cardiac arrhythmias. So once it's gated to the patient's EKG, the AccuSync device detects the rising slope of the R wave, and it sends a signal to the nanoknife machine. And then there is a 0.05 second delay, and then the machine delivers a pulse. So the pulse is delivered just before or right during the refractory period, thereby reducing the risk of cardiac arrhythmias. So each treatment pair requires 70 pulses. So to complete a treatment, you need 2 needles and 70 pulses. So these pulses are delivered during the refractory part of the cardiac cycle. All of these patients are discussed in our tumor board, and then they're seen in the office in a consultation with both interventional radiology and anesthesia. All of these procedures have to be performed under general anesthesia. Unlike other ablative techniques, you cannot do this under conscious sedation. You need complete muscle relaxation. It can be done with CT or ultrasound guidance. And the interface of this technology is different from what you would see with thermal ablation. You have the screen in the touch screen of the generator, which kind of gives you a depiction of the yellow circle is the tumor. The numbers are where the needles are placed, and this little blue circle is the head of the patient. And the light blue kind of gives you an idea as to the kind of margin that you're going to get. And on your left, you see the dimensions of the tumor that are plugged in. So when you do thermal ablation with RFA, you typically go to the deepest part of the tumor. You do one ablation, you retract the tines, you pull it back, and then redeploy do another ablation, again, pull back and do a third one if you're building a compound lesion, the concept of overlapping spheres. With IRE, again, the interface in the machine is a little different. So this is a cartoon that shows you how this works. At any given time, irrespective of the number of needles you place, the energy is only going to be delivered between 2 needles. So assuming that this is a tumor and you have placed 4 needles, on your left-hand side here, you see the interface which will be programmed by the engineer that is usually there with us whenever we do this procedure.
Sound is not quite good. If you could.
Okay. Can you hear me now? Is that better?
Yeah, it's working.
Okay. So you can deliver up to a maximum of 1,500 volts per centimeter. So here you can see the distance between needle 1 and 4 is 2.2 centimeters, but you can still only get a maximum voltage of 3,000 because it's 1,500 volts per cm. So for 2 cm, you're going to get 3,000. So even though you're a little over 2 cm, you're still only going to get the maximum of 3,000 volts. You can add or subtract pairs. So you can just do 1, 2, 2, 4, 4, 3, and 3, 1. Or in this particular case, we're doing 2, 3, and 4, 1 to complete the treatment. So once you have all the parameters set, the number of pulses used to be 90, but we've now gone to 70 pulses. So you don't have to do 90 pulses. When you turn the machine on, it's going to deliver 70 pulses between probes 1 and 4. Then it automatically switches between probes 2 and 3, 2 and 4, 3 and 1, 3 and 4, and 1 and 2. And this is how you would create an ablation zone with IRE. So you need to discuss with the anesthesiologist when you set up the program. You require complete muscle blockade. So once you're about to deliver the energy, you want to have the anesthesiologist check for the twitches. They have what's called a twitch monitor, and you want anywhere between 0 to 1 twitches before you deliver the energy. And you also want to turn off the AccuSync device because it can interfere with the generator. And all of these patients, before you start the procedure, they would place the defibrillator pads just in case they have to shock the patient. That's something that's done. And this is a little video of how to position the patient. If you keep the hands behind the head of the patient, you could have a potential for brachial plexus injury. So what we do is kind of a low-tech method. We stack up a bunch of towels and tape the patient's hands across so that their hands are not above their head, and that reduces the risk or eliminates the risk of brachial plexus injury. And the needles are pretty sharp, and it's a 19-gauge diamond tip needle. And once you expose the active tip, you can make a small incision and advance the probe. After all the needles are placed, we do a 3D reconstruction, which can be done with any CT machine. And you look at the actual distance between the needles. You want to be between 1.8 to anywhere between 2.2 to 2.5 cm. You don't want to go more than that because if you have a bigger separation, you're going to have areas of high current errors or skip areas where you're not going to be able to treat the lesion. After you have, you're ready and you start the generator on, you're typically going to see this. So that is very unique for a nanoknife compared to microwave or IRE, compared to microwave or cryoablation. So even with complete muscle relaxation, you're going to see some movement of the probes. Usually it's not a problem. A couple of times I've noticed that the needles have moved a little bit, so you need to keep an eye on it until you get comfortable with the technology to make sure that there's not a big movement in the needle. Once you're done with the ablation, we do a contrast-enhanced CT. So typically you see lack of enhancement, an exaggerated hypodense area with the peripheral hyperemia. And because of the apoptosis, you start seeing decrease in the size of the treatment zone, usually starting in 1 month of the follow-up imaging. And this is more pronounced in the liver. You don't see it much in the pancreas, but when you do ablations in the liver, you start seeing a decrease in the size. And one of the advantages of the technology is you will see preservation of the vessels in the treatment zone. So here's the patient who was treated both with RFA and IRE. The initial HCC was treated with RFA, where you can see a new lesion was formed right next to the recanalized umbilical vein, and that was treated with IRE because it's safer to use IRE near blood vessels. And a month later, you can see the IRE zone kind of blends with the background, but the RFA lesion still pretty much looks the same. So here's the pre-treatment, same patient, a different lesion a few months later. This was again treated with IRE with 3 needles, and you can see the hypodense zone with the peripheral hyperemia. That's the typical post-ablation zone that you would see. And this is in May, and if you look at it in June, you can see it kind of starts to blend with the background. Same patient a few months later. The first lesion that was ablated between right and left lobes, you can barely see it. And the second one that was ablated, you can see it kind of blends with the background. And there is some progression of the patient's disease. You can see the ascites now. So here's another example where you see a marked decrease in the size. This patient had a single lesion, metastatic lesion of neuroendocrine tumor in the left lobe that was ablated. Since it's a not thermal technique, you don't have to displace the stomach. This was immediately 24 hours post. 5 weeks later, you see it decreases in size, and by 5 months, it was completely, you can barely see the ablation zone. This patient went on to have a portal vein embolization on the right, and then had a Whipple with an extended right resection. She had multiple metastatic lesions in the right lobe, but only one in the left, which was ablated. And the same patient now in 2011, and we treated her in 2010. In 2020, she's still around and doing well, and this was a stage 4 metastatic neuroendocrine tumor. This was her follow-up from 2017, and again, I recently spoke to her in 2020. So for the rest of the talk, we're going to look at the role of IRE in pancreatic cancer and colorectal mets. What is the effect of IRE on blood vessels, some of the niche applications, and what are some of the challenges? So pancreatic cancer, this is a technology that I use exclusively in the pancreas. Back in 2010, IRE, one of the main advantages was thought to be a role in the pancreas and was used by surgeons in an open approach in the pancreas to treat pancreatic cancer. So I did the first percutaneous IRE of the pancreas back in 2010. And the rationale being that we thought we could potentially downstage some of these patients to surgery. As you know, pancreatic cancer is a pretty dismal prognosis. A very small percentage of these patients qualify for surgery, 10 to 20%, and vast majority are treated with chemotherapy and radiation. And interventional radiologists predominantly are only there for palliative procedures. And depending on the encasement of the vessel, you can see the vein and the artery. There's a nice fat interface here. This would be a resectable patient. If it's less than 180 degrees, you have a borderline resectable patient, and an unresectable patient where there's complete encasement or more than 180 degrees. Again, a lot of this, the borderline resectable cases depend on the experience of the institution. If you work in a place where the surgeons are very experienced and they are comfortable doing many of these, they might take on cases which other institutions will not. So our goal was to try and see if we can destroy the tumor right next to the vessel interface, thereby helping the surgeon get an R0 margin. And so, like I said, the first one was done in November of 2010. The idea is similar to what I showed you before. You try to bracket the pancreatic tumors, try to keep the distance between the needles between 2 to 2.2. And once you have the needles in place, you're delivering the energy and one pair at a time. And here it's going across. And this is typically how you would treat pancreatic cancer. Patient selection, ideal patients would be your stage 3 patients. We've done a select number of stage 4 cases, patients with metastatic disease. And ideally, this is not a technology for stage 4 patients. If a patient with stage 4 has exhausted all the treatment options, has a very small amount of metastatic disease in the liver, meaning less than 3 lesions, and they're stable 8 weeks after their last chemotherapy, then we offer them IRE. Otherwise, we do not. This is reserved mostly only for stage 3 patients. So tumor board, important. We have an IR console. It's important to have a metastatic workup for the pancreatic cancer patients within 1 month of the procedure because their staging could change. So I use a PET scan as a surrogate for a laparoscopy, which the surgeons would do. So once the PET scan is done and does not show metastatic disease, I'm comfortable treating the patient. And then I also use a bowel preparation 24 hours before the procedure, like what you would do for a colonoscopy. Sorry. So the day of the procedure, we use CAT scan guidance for all our procedures. I do not do this under ultrasound guidance. There are some practices that use ultrasound guidance. My personal bias is I feel that the precision is much better with CT, and then you can also get a post-procedure contrast-enhanced CT. Thereby, you can see whether there's any damage to vessels. You need general anesthesia. And then the NG tube, I started out using surgical NG tubes, and the patients complained more about the NG tube than the procedure. So we switched to 5-French catheters. And once the NG tube was in place, after a few cases, we realized that if we inject oral contrast, that is going to give us a better delineation of the stomach and the small bowel, and thereby we can place the needles more precisely. So now we give oral contrast a few minutes before we start the case with IV contrast and do an initial scan, then plan the needle placement, and then proceed. That's become part of our standard protocol. We give 150 ml of dilute oral contrast. What are some of the challenges for pancreatic cancer? Percutaneously is to try to find a window. Sometimes the colon is going to get in the way. I typically try not to place a needle through the colon. There are our colleagues in King's in UK who have placed needles through the colon to access the pancreas. I'm always concerned about the possibility of infection, but they've seemed to have been doing this. So when I have the colon in the way, I typically use a compression device or a compression, the pressure band that you have in a CAT scan room, where you can cut a rectangular opening and then use the Velcro to press on the patient's abdomen, thereby trying to push the stomach. You can also inflate the NG tube or the catheter, put some air through it, and see if that would displace the colon. These are all some of the things you can do. In this particular patient, we were able to get a window after we moved the colon, and but when we advanced the needle, we had I think I have the images somewhere else, but that patient ended up having a small bleed, and we had to abort the procedure. Here's another problem which you might see in patients who have splenic artery, superior mesenteric vein occlusion, and therefore they have varices, and this could be a problem when you're trying to place your needles. So this particular patient, this was one of the early patients that we treated, and when we saw the varices, we thought it was not safe. So in order to decompress the varices, we went back and did a splenic artery embolization, and in about 2 weeks, we brought the patient back, and you can see that the varices were all decompressed, and then we were able to treat the patient after we did the splenic artery embolization. So that's something you can use if you feel that the varices are going to be a problem when you perform pancreatic ablation. So here's the same patient that I showed you before, the bleeding, where I'm trying to adjust the needle to go a little more medial, and then in the third image, you can see the hematoma forming. We stopped the procedure. Patient was managed conservatively. This all bleeding that is tracking down, and patient did not require a transfusion. But something to keep in mind, it's a sharp needle. You can have all kinds of complications you can expect from an ablation needle, but the technology is safe near blood vessels, but you have to be careful when you are placing the needle. So here is pancreatitis, which is another complication you can see in patients with pancreatic ablation. The CT looks more dramatic. Patients usually have mild abdominal discomfort or pain. You manage them the way you would manage any pancreatitis. You keep them NPO, and usually the amylase and lipase starts turning down within 24 to 48 hours, and then you can slowly start feeding them with liquids, soft solids, and then if they tolerate that, then you go to a full meal. Here's a good example of a patient with a percutaneous pancreatic IRE. This patient was young, 41 in 2016. very good performance status, had biopsy-proven pancreatic cancer, treated with chemotherapy and radiation, and still had local recurrence in the body of the pancreas, and was given 3 months to get his things in order when he came over to our institution. I treated him with 4 needles the first time. I used a transgastric approach, so going through the stomach, and you're placing 2 needles in the superior part of the tumor and 2 in the inferior part. Now, once you bracket the tumors appropriately, as you can see, you are like millimeters from blood vessels here. And this is the final CT of the patient. The blood vessels were intact. There was no vascular complication. And he was discharged the very next day. This is the patient CT 1 month later. When you do pancreatic IRE, you might not see a big difference in the CT. What you see here 1 month later is a slight change in the enhancement, looks slightly hypodense, but if you're using RECIST criteria, this would be called a stable response. But when you look at the PET scan of the patient, that's before the ablation, and this is the PET scan of the patient after IRE, now that tells you a whole different story. So just using anatomic imaging or CT or RECIST criteria is not the best way to assess response for local regional treatment for pancreatic cancer. And we're currently working on a project to come up with a new response criteria when you treat the pancreas with local ablative therapies or local regional therapies. Same patient, 19 months out, still no evidence of local recurrence. Patient is no longer on chemotherapy. Again, first treatment October 2016. We're now in July of 2020. Pancreatic cancer patient still doing well. So this is, again, one of the best cases, one of the best outcomes that I've had. Some of the data I would like to share with you. We published the first human data in 2012 in 14 patients. We managed to downstage 2 of these patients to surgery. One of them is still alive. And the first patient that we treated who was downstage had got 5 more years after the surgery. We followed this in 2017 with another paper, a retrospective study of 50 patients who were all treated with IRE. All of them had biopsy-proven disease. And the primary objective was to assess the safety of the technology. And the secondary objective was to look at the overall survival. And so all of these patients had chemotherapy before, and 60% of them had radiation. We had CT follow-ups at 1 and 3 months, and the median time from diagnosis to IRE was 11.6 months. So those of you who follow pancreatic cancer, 11.6 months or 11 months is typically the average you would get for patients with stage 3 who've just had chemo and radiation. Clearly, our patients that were sent to IRE there was a selection bias because they'd already survived past 11 months. Some of the adverse events was mostly abdominal pain, pancreatitis, sepsis in 1 patient, gastric leak in 1. Our median overall survival was a very healthy 27 months from the time of diagnosis and 14.2 months from the time of IRE. Again, this compared to what you could really see in a pancreatic cancer patient, this was a really good results that we had. We did not have any 30-day mortality. When we did multivariate analysis, we found that the size of the tumor was the only independent predictor. Anything less than 3 centimeters, the patients did much better than those that were over 3 cm. So when compared with the largest surgical series, which was from Louisville, that was published in 15 of 200 patients from 5 centers, patients with de novo IRE and margin accentuation, the overall survival was 25 months, and our series had a 27-month overall survival. This is a small series from Japan of 8 patients by Dr. Sugimoto. 4 patients had open IRE, and 4 of them had percutaneous. 50% of them had previous radiation, and median time to local progression after IRE was 12 months. Median overall survival after IRE was 17.5 months, and median overall survival from diagnosis 24 months. This is another big retrospective series from Eddie Lean from the UK in 2018, 75 patients, and all of them were treated with percutaneous IRE. And The hospital stay, the median was just 1 day, and the overall survival and progression-free survival post-IRE was 27 and 15 months. And they managed to downstage 4 patients. So when you summarize these 3 retrospective papers, when you look at the overall survival from diagnosis, you see that the numbers are pretty close. 2 of them are almost identical. And the overall survival from IRE, we got 14.2 months, Lean had 15 months, and Sugimoto 17.5 months. So clearly there's a signal, even though this is retrospective, single center, possible selection bias, you see a very clear signal that there is a potential for improvement in survival. So what do we do and where do we move from here? After many years, nearly a decade, we finally convinced the FDA in the United States to allow us to do a IDE-approved randomized controlled trial, and that's the DIRECT study, which is data for IRE cancer treatment. This is very unique. The study is up and running in the United States now. It's the first time we're going to have a controlled registry along with a randomized controlled trial. When you have an RCT, typically you have difficulty enrolling patients because they usually want to be in the new technology arm and not be randomized to what could be, say, more chemotherapy in this particular case. But here, both the registry and the RCT would have a control arm, and the idea would be patients would be a stage 3 pancreatic cancer patient who would be started on induction chemotherapy with FOLFIRINOX, and then they would be randomized to either NanoKnife plus chemotherapy or just NanoKnife. Or just chemotherapy, I apologize, which is typically the standard of care main centers which do not have access to NanoKnife. And the idea is to see if there is going to be an improvement in the survival after by adding NanoKnife. So we're excited. We are starting to enroll patients at the registry. I think the RCT has 1 patient enrolled now. There are a few sites up and running, and Rob Martin and I are heading the study in the US. So what are some of the future directions, especially in pancreatic cancer? Animal studies have shown an improvement in the immune response after IRE, especially in this paper in Nature, where IRE reversed the resistance to immune checkpoint inhibitors in a mice model, which, again, as you know, one of the key barriers for chemotherapy in the pancreas is the stromal tissue. And if we're able to reverse the resistance to immune checkpoint inhibitors in pancreatic cancer, that would be huge. So there's positive signals in this animal study, and we'll see how that translates to humans. So here are some of the survival studies in pancreas, and you can see the 2 IRE studies have shown the highest survival to date, and the randomized control trial hopefully will give us shed more light into this space. So the ideal patient for percutaneous IRE of pancreas would be a stage 3 patient with an ECOG of 0 to 1, somebody where you can safely reach the tumor, somebody who's completed at least 1 line of chemotherapy, and a size less than 3 cm. Why do you do percutaneous when this is done open in many centers? Percutaneous offers you the advantages of being minimally invasive. You can place the needles precisely with CT guidance. The results are similar or even slightly better than the open technique. The morbidity in the hospital stay is extremely, extremely different. It's much less. You don't have to do a bypass. You don't have to keep the patient in the hospital for a week. They have a 1 to 1.5 day stay in the hospital. And you can also do an immediate post-ablation imaging with contrast so you can visualize what's happening after the ablation. What are some of the cons? It's not for all patients. You might not be able to move critical structures in some patients. Therefore, they would need an open approach. When you have a bleeding complication, we cannot do what the surgeons do. We have to move the patient to an angio suite and then do an angiogram, or if it's a varix, again, you don't have the options or advantages that the surgeon has. Having said that, I think the percutaneous technique has definitely gathered momentum. It's no longer just performed in a few centers. It's done in a few sites in the US, but it's used quite a bit in Amsterdam, Italy, the United Kingdom, Japan, and China. And NICE, which is the FDA equivalent of the UK, in the UK, has authorized a randomized control trial in the pancreas with IRE, but mandated the percutaneous approach and not the open approach. So clearly there is acceptance to this technique. And so some of the take-home points, you need to be safe. It's still a needle. You got to select your cases carefully. Initially, don't pick a case that could potentially not give a good outcome or get you into trouble. You need a little bit of a couple of cases in your belt before you embark into the pancreas. Your workup of the patient is very important, and we've definitely shown that the technique is reproducible. So the overall survival numbers make a compelling case. It has been shown to prolong survival, and in some cases has leads to resectability of the disease. Colorectal cancer, very briefly, I use it only in patients where you cannot, it's small amount of disease, near critical structures. If this multifocal bilobar, we still use Y90 as our approach. Here's a patient. This is the first human experience that we published in 2014. We also proposed a response evaluation system in this paper where we said that you need to assess colorectal cancer treatment, again, not just with CT, but with a combination of PET, CT, and tumor markers. So here's an example of where I would use IRE. This is a patient who had a solitary focus right at the crux of the hepatic vein, very high up, and that's a PET scan. This is not a patient that would be treated surgically. Because of the location near the veins, you would not use thermal ablation for this. And because it was just a solitary lesion, you don't need to use Y90 for something that focal. So this was treated with a single treatment. That's the PET scan after 2 months. You no longer see the uptake. 8 months later, you can still see the vessels are patent with no evidence of local recurrence in this particular patient. So this is not something you would need in all patients. We use it very selectively, again, if it is near critical structures. Patient early experience with IRE, where we missed and did not get a good response. This should have been a slam dunk case. This was very close to the margin and edge, and so we thought, IRE would be safer than thermal, but we missed it. As you can see, there was local recurrence, which came back within 3 months, and patient had to go to surgery afterwards. So what's the effect on vessels? We wanted to see what was the effect of vasculature. This was a paper we published in 2013 in CVIR, and 101 patients, 129 lesions. The reason IRE is safe near blood vessels is predominantly non-thermal. The collagen skeleton of the blood vessel is preserved, even though there is damage to the intima media and adventitious. So the blood flow is preserved, and therefore you're able to go near critical structures. In our retrospective study, we looked at 100 patients, like I said, 101, and all the patients, the vessels were within 1 cm. The majority of them were within 5 millimeters, and most of the times the changes that we saw was 7 vessels, and they were all in portal vein. 3 of them had mild narrowing. 1 was a non-occlusive thrombus, 1 partial non-flow limiting thrombus, 1 left portal vein thrombus, and 1 complete main portal vein thrombosis. That was a patient with pancreatic cancer who had complete encasement of the portal vein. So something to keep in mind when you're treating a tumor that's completely encased by the portal vein. When you're going to ablate it, it's going to cause swelling. It could compromise the flow through the portal vein, which is a low flow state. So typically you can potentially use anticoagulation in those patients for the first 10 days, which is what I do. Here's a patient, another patient right on the portal vein, which was treated with 5 needles, but the portal vein remained patent at 1 month, and the lesion was treated appropriately. So something to keep in mind when you are near the portal vein, but if it's encompassing the portal vein, anticoagulation is something that could help you. Some of the niche applications very quickly, treating lesions which you typically would not treat with other ablations is possible with IRE. This is a metastatic neuroendocrine lesion going superior to inferior, enhancing lesion right next to the stomach and celiac axis vessels. Not an ideal location for a thermal ablation. This was treated with 3 needles, and this is the immediate post. You no longer see the enhancement, and that is the octreous scan of the patient, where you no longer see the uptake in the treated zone. Another one, metastatic neuroendocrine node right next to the aorta. This was treated with IRE, and no uptake in the follow-up octreous scan. Lesions next to the gallbladder, typically you would need to either move the gallbladder with dissection or use an arterial technique. Here with IRE, we were able to treat it with 5 needles without any separation of the gallbladder, no injury to the gallbladder, 1 month follow-up, 6 months, and 15-month follow-up. Patient went on to have a successful liver transplant. So that's another advantage. Here's another complex patient, HCC that recurred after transplant, right next to the aorta and the renal vessels. The renal artery was running right through this tumor, which grew pretty quickly within 4 months. And this was biopsied, was HCC. Treated this with IRE and with 4 needles. Sorry. We're missing an image here. I apologize. This was treated with IRE. On the far right, you see the post-IRE treatment scan, where you can see the vessel running right through the treatment zone and it's patent. Same patient at 1 month post, the lesion treated, no more enhancement. 15 months later, there was a local recurrence. Again, you can see the renal vessel running next to it, was retreated with IRE. We managed to give the patient 5 years of chemo-free life after the first recurrence outside the liver in this transplant patient was treated with just IRE. And finally, here, metastatic disease. This is a pancreatic cancer patient with a positive node right next to the colon, was treated with IRE without separating the colon, and you can see the PET is negative. Another last example next to the rectum and the bladder, metastatic disease from ovarian cancer, biopsy proven. Again, you can see the PET, no side effects or complications to the adjacent structures. So some of the challenges you have is your learning curve. You have to place the needles in parallel, so that could be a challenge. The cost is still probably the most expensive ablation tool out there. So compared to chemo, it's probably a lot cheaper, but in the ablation world, it's still expensive if you're using 4 needles or 5 needles. The patient selection is important, and standardizing the follow-up is also critical. So when you not use IRE, my very first patient in 2010, January, this was an HCC segment 8 lesion, trying to climb, avoid the lung, and go through the ribs and place 3 needles. Took us 8 hours to do this procedure. So for a case like this, you really do not need IRE. You can do this easily with a TACE, or if necessary, even an ablative technique like microwave. But IRE, this was our very, very first patient that we did, and we learned it the hard way. So where does it fit in our practice? Again, I work in a practice that uses all the ablative tools. We use microwave, cryo, IRE, and Y90 and TACE. So it has not replaced any of our other techniques, but it has been a good adjunct. It helps us treat locations we typically would not treat with other ablative tools or transarterial tools. It's proved to be a very valuable addition in the pancreas program. So these are some of the areas where we see that it has played a vital role in our practice, but has not replaced any of the other tools that we use. So that ends my talk. Thank you very much for the opportunity again. I'm happy to take any questions at this time.
Thank you very much, and congratulations for your talk, Rajan. Qualquer que queira fazer pergunta pode colocar aí no bate-papo, a gente vai tentando selecionar. Rodrigo, você quer começar aí a moderar?
Excellent. Thank you, Raji. Very nice for this very nice presentation. I would like to ask something in terms of post-procedure care. Is it painful?
Yes, it is. It is painful. You do need general anesthesia and you need deep sedation. But once the patient recovers from the anesthesia, the pain is much better compared to thermal ablation. They're not in a significant amount of pain. Usually they don't use the PCA pump as much. Pancreas patients, different story, but patients for the liver, kidney, usually they tolerate it very well. And but during the ablation, you do need general anesthesia with deep sedation.
Rajan, you show very complex cases and local advanced tumors, particularly in pancreatic cancer. Do you think that IRE can really get a complete ablation, do you have a more long follow-up? Because sometimes even with surgical resection, we see local recurrence. How is the amount of local recurrence that you had in this?
Yes. So when you do IRE, again, your experience and the technique matters. It's not a silver bullet where you're going to have no local recurrence. So it is like every other ablative tool. It's only as good as the margin that you get. In pancreatic cancer, obviously, our goal is not to go for a cure. We're trying to give these patients another option, which would not have existed. They would have typically gone to a trial after 11 months, but now we're able to give them another option. So to answer the question about local recurrence, usually in the liver, if you do it right and if you get a good margin, we've had patients 4 or 5 years without any local recurrence. Whereas in the pancreas, typically you go, like I said, most of the patients, the average survival is 14 months. There is a small number of patients where I've gone back in to re-ablate, but they have progression of disease outside the pancreas. Pancreas, a lot of people would argue, is a systemic disease. And even when you diagnose these patients, even though it's a stage 3 on imaging, they could probably be the cancers out of the panc, but we've not seen it in imaging as yet. So with that rationale, what we're doing locally is typically not for a cure, but to give these patients an extra tool to see if we can prolong their survival and give them a quality of life.
Good. Haji, we have a question for audience. Yes. Do you have experience in thyroid cancer, in thyroid bossu?
No, I have not used IRE in the thyroid. What we do is we do alcohol for the lymph nodes and any remnant in the parathyroids, but I've not used IRE in the thyroid.
The same for prostate cancer?
Prostate cancer, we are just going to start our first study, prospective trial in prostate cancer with IRE. It has been used extensively in Europe, and they have published quite a bit. In the US, it's been done off-label, but with doing the first safety study with 6 patients should be starting very soon. But it has been used quite a bit in Australia and in Europe.
And Haji, do you have any experience or started some protocols using IRE associated with these immunotherapy drugs?
No, we have not done combination with immunotherapy as yet, but hopefully that would happen down the road.
But you believe you have usually right now cryo is doing a good job in that area. You think IRE have a field to grow in this area?
Yes, I definitely think one of the biggest limitations or disadvantages that the IRE had in the US was the lack of reimbursement. And so it took the study by the FDA to finally last year for the CMS in the US to give us codes for reimbursement. So right now, any patient who's enrolled in the study or in the registry is fully reimbursed, and therefore there's more interest now in the technology. That has been one of the limitations for more widespread use of the technology. But to answer the question, there was a publication in JVIR that compared cryo with IRE and the immune response in animals. Dr. White published that study, and IRE had a better immune response post-ablation compared to cryo. So we actually had a protocol very early on to use the reversible zone in pancreatic cancer to see if we are able to get more chemotherapy to penetrate the stromal tissue, but that has not seen the light of day. And finally, I think now with the IDE, this is the first study. I'm sure there's going to be more, but I think we're at a point in the next few years, this technology should be mainstream very soon.
We have another questions here. Technically speaking, how do you program how many needles are you going to use?
Okay, so it depends on the size of the tumor. Typically, any tumor that is less than 2 cm, we would go with 2 needles. Up to 3 centimeters, it's between close to 4 needles. The machine that's sold outside the United States has a planning software. In the US, the planning software was not allowed by the FDA, so it was removed. But outside the United States, you can actually place the needles in the model, in the machine, on the screen, and it'll tell you the margin that you're going to get. So in the US, we're not allowed to use it. So I typically go with more with my experience as to how many needles I'm going to use. If it's a 3 cm tumor, I would typically use 4 needles. But I think outside the US, you do have the help of the software to guide you as to how many needles you need.
For liver ablation, for example, when do you, as you have all the, you have microwave, you have RF, how do you select ROE? Which are the cases that you think are, this is a perfect case for ROE in liver ablation?
So if I understood correctly, the question is, when do you use IRE versus microwave ablation? So if a tumor is away from critical structures and it can be treated safely, my preference would be thermal ablation, which is microwave, because you use a single needle, it's quick, it's fast, you can get a good margin, and you can be done with it, relatively inexpensive. The time I use IRE is if it is near a major blood vessel, near the colon, near the gallbladder, near bile ducts. So these are the locations where I would typically use IRE versus microwave ablation. And if it's a multifocal disease, I typically go with an arterial technique rather than using a needle-based technique.
Okay.
I have some questions that popped up. Do you want me to answer those?
Rodrigo, você pode fazer a pergunta aí.
I have some questions on my screen.
Okay, go ahead.
Oh, there was one question that says, why did you change to 70 pulses? That was a protocol that was given by the manufacturer. They realized that you can cause cell death with 70 pulses, so we went down to 70. Then there's another question that says, how is the surgeon's experience after pancreatic IRE with regard to resectability? And do you think it has a role in borderline pancreatic cancer? Yes, surgeons have a lot of experience with pancreatic IRE, and they use it in 2 conditions. One, a de novo patient who's not a surgical candidate, they do an open IRE, and Dr. Martin uses it a lot for margin accentuation in borderline patients where they think that they want to get an R0 margin, so they clean the margin with IRE and then do the surgery afterwards. So yes, it is used extensively by the surgeon. So then there's another question that says, when will we have IRE in Brazil? I do not know the answer. And what is the cost compared to RFA and microwave? In the US, if you use a single microwave, it costs anywhere, the probe costs from $2,000 to $3,000. The NanoKnife in the US runs between $1,800, $2,000 per needle. So it's about, I would say, 2 to 3 times more than using microwave. And then the next question is, the best point of IRE is the precision to spare contiguous structures. Is that correct? Yes, that is correct. And is it predictable? Yes, it is very predictable. That's one of the things I like about it, is that it is, you get what you see is what you're going to get. It's not a guessing thing like typically with microwave. I have to use more of an experience and extrapolate the animal data to humans to see what kind of ablation zone we're going to get. Whereas with IRE, it's pretty predictable. Average cost, again, depends on the number of probes that you use and the institution. It varies from institution to institution. So I cannot give you an exact cost, but usually when it's covered by the insurance, they take care of it. When bleeding complication occurred, in which moment was it? When the needle positioning, after treatment, or both? So The times when I've seen bleeding is when during the needle placement. I've had 2 cases where we had variceal bleeds, where we managed conservatively. I've had a renal cell carcinoma, which bled a little bit to the periphery, even though we embolized it before. And I've had a neuroendocrine pancreas that bled, which was also a contained bleed, all of them during the needle placement. So that pretty much answers all the questions I have here.
Haji, how can you tell us your fears about IRE? What are your fears when you use IRE?
When you use IRE, I think one of the key things to keep in mind is what I said during the talk, not to feel cavalier or comfortable that because it's safe near a vessel that you're not going to have complications. Since you're placing 3 needles instead of 1, you have three more chances of having a complication with the needle compared to microwave. So my advice would be to be careful, to be vigilant, and not get too comfortable and say, okay, we got this and it's going to be, there's going to be no issues. You have to plan your trajectory properly, and you have to be very good and precise with your technique. So that is my biggest fear, is always when you place needles, you're going to have a complication. My next biggest concern always is how my patients are going to post-ablation and how they're going to tolerate the evening after the ablation. So I always make sure that we round on the patients to see how they're doing. I make sure they got the medications for the evening, their diet. So the follow-up of the patient is also critical. I think if those 2 are usually my biggest concerns when I do these.
Well, sorry about, you know more about cardiac arrhythmias following the procedure?
Yes.
Is it there is concern about?
Yes, I have seen that happening. Patients who have a history of cardiac arrhythmias are more prone to have a cardiac arrhythmias during the ablation. This is not a procedure that should be offered in a patient who has a history of atrial fibrillation or patients who have a pacemaker. Having said that, we did this once in a patient who we did not know had a remote history of cardiac arrhythmias. The patient went into an arrhythmia which was controlled. We have done one patient where we've turned the pacemaker off because the patient could have it turned off. But in my experience over 10 years, I probably have seen this 3 times where we've had cardiac arrhythmias in patients.
Mainly the complications that you have, Haji, are bleeding. Other collateral damage, because as you are not dealing with thermoablation, besides bleeding, what can you tell about complications in terms of
what we've seen in addition to bleeding is pancreatitis is something to keep in mind when you are dealing with the pancreas. In the literature, they have described pseudoaneurysms after a ablation. That is always something of concern to people when you're placing a needle. So there is a debate whether it was the needle that caused the pseudoaneurysm or the technology that caused the pseudoaneurysm. The jury is out. Again, in my experience, I've not seen the technology causing pseudoaneurysms because we've over 800 patients at this point. We would have seen a significant number of pseudoaneurysms if the technology was the reason. I personally think that it could be secondary to needle placement. The other things, like I said, sepsis, anytime you have a patient with a biliary stent, it's important to put the patient on antibiotics before and after. So we start the patient on moxifloxacin at least 1 week before the ablation and continue for 1 week after the ablation to reduce the risk of sepsis. So that's something to keep in mind. So these are all some of the complications that you can have with the procedure.
Alguma outra coisa, Rodrigo? Vai ao fim do nosso tempo.
Just that from.
Oh, any other questions? I think we are achieving our time here, and you must be tired of your tough case, Haji. Again, I want to say,
my pleasure. Thank you very much for the invitation. I've been to Sobrice a couple of times. It's always wonderful being there. very friendly and hospitable group. And I've met some of your colleagues who've come here to Miami. So you're all welcome. If you want to come over, feel free. Just drop me an email, and any help, happy to do that.
Thank you very much.
Thank you very much.
Thank you. Congratulations on the meeting.
You are now a Sobrice member from.
Thank you.
So,
Thank you. I'm honored. Thank you.
thank you very much again.
Bye-bye.
See you soon.
Bye.
Bye-bye.
Obrigado a todo mundo que participou nesse primeiro Sobrice Solidário. Esperamos aí que tenha uma série de ações e de webinars com conteúdos bastante interessantes. Também ali no chat estamos abertos a sugestões. Eu acho que a gente está vivendo esse mundo digital, esse mundo conectado, onde a gente pode aí interagir e educação, informação e colaboração está aí a todo lugar. Muito obrigado a todo mundo. E eu queria agradecer especialmente aí a AngioDynamics pela colaboração no webinar e na ação solidária que nós vamos estar fazendo agora em Recife na próxima sexta-feira. Obrigado a todos.
E aguardando a chegada do equipamento no Brasil, né, Marcos? Ansiosamente, né?
Isso aí. Boa noite, gente.
Boa noite. Tchau, tchau.